That's right. I mean, we used WashU because it was designated as non-human subjects research, and they really followed that those requirements pretty carefully. And thus far, other IRBs have not had any issues with it. So far, we have 53 patients that are in the database. There's actually a tab for current data so that you can actually see that on the COVIMS homepage. So again, it will take time to be able to really infer anything about the factors that potentially be involved, but we have to get this thing started. The other good news is that the data here, or the data collection, are harmonized with some of the other worldwide data collections, such as the Italian district, which has many more patients. But over time, it's believed that we'll be able to take a look at these data collectively, and perhaps sooner rather than later be able to make something out of it that can be helpful in clinical decision making.
We have some background.
Yes, what happened? I'm on, but I can't talk or be seen. So Doris gave me the phone. So I don't know what to do quite now. I don't know why.
I think
when you have the phone and computer, you get an echo, but I can't.
Is yours on?
Bob, it's important for you to turn the audio, the secure audio off.
Yeah, everybody who's on and not.
Okay. But I got it off, but there's no reason why the link shouldn't work both ways. It really should. But anyway, I've been on a while, watching all you guys. By the way, the Wayne State wants their own IRB, but we've got expedited review already. We're already set. We've got 3 patients to enter. And one of our residents, one of Mahmoud's co-residents, Gia Lynn, is going to sort of honcho that one with Ava Benitzis and Jacob Ruby and I, and we're also on the MG one with David Char and myself. So that one's, I think, through the NIH rare disease. I think all the neurologic diseases and other diseases. I know that the inflammatory bowel is doing stuff out of Chapel Hill. So I think all of the diseases are going to look at this issue, which is an important one, obviously.
Very much so. Very much so.
Great.
And Kathy, do you have a third item?
I do. Just to let everyone know, tomorrow evening at 7 p.m. Eastern, there will be a webinar. It's more of a town hall kind of setup because it's a Q&A session from 7 p.m. to 8 p.m. And Sarah might be able to put up a slide as we move forward with the actual registration information. We have Avi Nath from the NIH, NINDS, and we also have Kieran Thacker, who is an inpatient neuroinfectious disease specialist at Columbia in New York City. And as you can imagine, she's quite an array of cases, both people with MS, but also people that are unfortunately developing neurological complications. And I think it will be very interesting to hear not only what she has seen, but what are they doing about this. So I'm looking forward to
Central Standard or Eastern Standard Time?
Eastern Standard. Thank you.
Kathy, are you sure it's on Wednesday? I thought it was on Thursday.
I'm sorry. You're right. Thursday. I have my days of the week. I mean, every day is COVID day for me right now. So
yeah, right. Got it. Same thing.
Thursday night.
Got it. Okay. So I thought it was Thursday. Abby's on.
Yeah,
right.
You're right.
At 7 Eastern. That's what I've got. Okay.
Yeah. Okay.
Let
Very
me
good.
just mention a call out to
Kathy, Elliot.
Yes.
This is
Yes,
Scott
hi,
here,
Scott.
and I just want to add to this, besides North American COVIMS, which is the physician-based registry, that separate from that, and you'd seen the CDC proposal, the white paper that I had submitted before, last week and even the week before, and then later this week, WashU, Columbia, Hopkins, ourselves, Pittsburgh have all been on with a really trying to harmonize a patient-based REDCap registry that can be used as well, which would be in parallel but not physician-based, with the intent of trying to capture even more patients than that we see in the center. So that's going through IRB approvals right now. Some of us have it, and that will probably be extended as well, and probably be harmonized with the larger effort at some point.
And if I may just add one final comment, and that is, I know we've heard lots of discussions on media that have been telescoped on culpability and should we have gone earlier and PPE and we need more ventilators. And I'll give a call out that we are finishing a manuscript which is provisionally accepted to the Journal of the Neurological Sciences and will be disseminated to the World Federation of Neurology. Avi Nath is going to do the editorial about this paper. The paper is a hypothesis paper on treating the 20% that either go down and go bad, or those who are already in a devastating circumstance, and potentially how to get them off. And this paper will review the basis of that in terms of these converging immune effector networks that are not coordinated and unregulated. So the registry data is going to be very important, but this is advancing an idea of what we might be able to do now with repurposing agents we already have while we're waiting for vaccine and other things. So look out for that. And Kathy, I will, as soon as it's done and I have permission, I will send it to you guys for dissemination for the group. We're all in this together. And it's really amazing the amount of synergy that we're hearing. So I think we'll go ahead and now transition and we'll get started.
By the way, Elliot, for the overlap, there are MG guidelines, again, guidelines not chiseled in stone, with Chip Howard on, although I think one of the European groups are the first authors for MG, and that's also already, I think, online available in J Neurologic Sciences as well on an EPUB, because some of the drugs overlap.
Point out, though, to underscore, this is not a position paper on MS with COVID. This is a position paper on COVID. This is really principally telescoped on the destructive obliteration of the peripheral alveolar gas exchange apparatus, and obviously there's a distribution of PTH receptors. So it'll have privacy issues for other areas. And somebody, we'll go ahead and start it. I'll turn off my audio. There's a very, very strange thump sound.
Sarah, can you mute the lines?
Okay. Fabulous. Okay, so I think we'll start it. So who's coming up first? Is that you, Sarah?
So I was just going to check to see if Dr. Chiang Rivera was on.
Yeah, let me look at the list.
Yes. Hello, Sarah. Yes, I'm on.
Hi.
Excellent.
So I just wanted to check with you and Dr. Shabib to see if one of you had a preference of going first. I didn't know if you had a conflict.
I think that's fabulous. That would be good as long as your team is in place and not running away. That would be fabulous.
Sorry, who's going first?
USC. You're going first.
Okay.
So
sure,
I will
thank you.
be the presenter then.
There we go.
Great. Can everybody see the screen?
Hold on, I'm still trying to make you the presenter.
So we have 3 tonight, is that correct?
2, I think.
If I'm not mistaken, I thought Doris sent around. I thought there was only 2. There was
Only
supposed
2?
to be 3,
Okay.
but I think there were only 2.
Perfect. Fair
Okay,
enough. All right, now we can see the
go off
screen.
camera and but keep the sound on. And remember, everybody, you can either interject or look at the chat box. You can send questions through the chat box, and we'll try to get to all of those. Okay.
So should I start?
Yeah, we need to change over.
Great.
Mahmoud is still on. We don't see you though. Are you going to come on camera? Or are you going to stay inconspicuous?
I was thinking of staying inconspicuous and start presenting the PowerPoint, if that's okay.
Yeah, it's okay. Unless you have kids in the background, but we love to see the kids. But go ahead.
I do, actually. So this is a case, it's a case that I got to see with my mentor, Dr. Amezcua, at the USC Keck hospital, and we've been following him. It's a 32-year-old Caucasian man. Previous history was notable for dengue fever when he in Cambodia many years ago in 2013. He had a history already of migraines with aura and also depression, but no other psychiatric issues. In December of this past year, he had acute symptoms. He was in Spain at the time living with his wife. He basically visual aura. He described it as black spots with bilateral visual obscurations. He remembers blurring of faces, lasting about 15 minutes, and then it was followed by intense migraine pain, very similar to his typical migraines, but much more intense. Nausea, emesis, and photophobia as well. He went to the local ED in Spain at the time, treated for migraine, and discharged. However, over the course of at least 20 hours upon coming home from the hospital, he began having a lot of confusion. He was agitated, had some aggressive behavior towards his wife, which was very uncharacteristic. Pacing back and forth, so there was a little bit of concern for manic episode, although he had never had anything like that before, and the family assures us. Basically, over the course of the day, he wasn't able to carry out any of his ADLs, including brushing his teeth, being able to pick up a utensil to eat, etc. So it was quite fast, quite drastic. He was confused to the point of, I don't know why he wanted to drive, but he got in the back seat instead of the front seat in order to drive. And then on the plane, on the flight home, he continued to be extremely encephalopathic. The wife described his behavior as that of a toddler.
Could we mute the other lines? And if I could just interject one thing, when you said it was uncharacteristically aggressive, yeah, he's been married how long? And could you just characterize a bit about how extreme was that aggressive behavior?
Yeah, so basically it was a lot of irritability. The aggressive behavior was never physical. The wife said that it was basically talking back to her, using some profanity, and being very short-tempered, which is very much different from his baseline personality. He's a very laid-back guy, highly educated, graduate studies in writing. He dedicates himself to actually fiction and also some nonfiction writing. And so he's that type of person at baseline, very thoughtful. Yeah, and they do have a toddler over 12 months at this point. So it's interesting that she also described his behavior similar to that of a toddler, and she was referring specifically to some of his inability to carry out simple tasks like eating using a fork, using a spoon, needing help with brushing his teeth. And this occurred very fast over the course of 24 hours. They became very concerned. So at that point, they booked a flight to return to the US. And that's when they came back to California. He went to Santa Barbara Cottage. So that was the initial workup that he had. He continued having severe encephalopathy, nonsensical speech, also continued having agitation. And so there was high concern at the hospital at the time for an infectious process. He was treated empirically for meningitis. And then towards the end of the hospitalization, it was made known that he had onset tinnitus, and also the visual obscurations had continued. And I will be showing you a few sample imaging coming up, but basically the workup that they did, the vast majority of it at Santa Barbara, was actually a vasculitis/stroke workup. And that's why you see on the screen the reason why he had, we'll go over the reason why he had these, but he had a conventional angiogram, was actually normal. No signs of vasculopathy there. And he also had a CTA head, neck. He had a TTE with bubble. All of that was unremarkable. The MRI, C and T spine as well. And then what I'll show you on on the following slides are some of the MRI imaging that was obtained at that outside hospital at Santa Barbara. What you see here, basically on the T2 flare, these are just two snapshots. You see some hyperintensities bilaterally in the cerebral hemispheres. And I wanted to show you a little bit of the T1 post sequences in which there is some leptomeningeal enhancement as
Horatio,
well.
Did he have an
Horatio, can I ask you
EEG?
a question about, I'm sorry, go ahead.
This is Scott. I just wanted to know, did he have an EEG during that admission?
He did, yes, he did, and he had subsequent EEGs too, which I'll get to. The one in Santa Barbara was nothing epileptiform, unremarkable.
And
Horatio,
there's also
Go
a
ahead.
question in the chat box from Andrew Goodman asking if there was any hearing loss.
I'll get to that very soon. You're
Horatio,
on top
could you
of it.
describe the visual phenomenology? I mean,
Yeah.
his history of headaches, has he
Absolutely.
had with aura, but what was it like, before we get to testing, I'm sort of with Andrew in terms of the semiology. What were these visual changes like, and were they reminiscent of anything he had previously?
That's an excellent question. So he had a history of visual migraines, with migraines with visual aura. They tended to be infrequent, like once every 3 or 4 months. The visual aura that he used to have was more of a sort of zigzag checkered pattern from what he had described to me. The ones that he started having in Spain were a bit different. He saw spots, dark spots in the visual field. He covered and uncovered each eye, and he said that it appeared to be in both eyes. He said it appeared to be throughout as well. And he and his wife both corroborated that it lasted about 15 minutes. And that's when immediately afterward, the very intense migraine pain set in. That was the episode in Spain. During the Santa Barbara hospital admission, he had what he described as visual obscurations, and it's documented in their medical records. Basically, he says that vision appeared to be very slightly kind of black, and I think he probably was describing a scotoma that he was perceiving. The issue is that he also described the black spots that persisted, and so this happened over several days. Each time that he noticed it, it was again about 15 minutes or so, and then they would resolve, followed by the migraine pain. So it appeared that he continued to have these very intense migraines with visual aura during the
And one other follow-up, and Horatio, very nice, beautiful characterization. Thank you for that. And I know you're moving along because you know time's of the essence, but we want to make sure you have time to really provide us with the story so we know where it was and where he's going. But when these resolved, the one in Spain and the one in Santa Barbara, did he and his wife report that he recognized that it was there, it was unusual, but did those visual changes completely resolve? Did he go back to baseline, or did he notice there was any visual deficit or anything that was residual and hung on even after the headache and the period was then prolonged, hours the next day, whatever it might be? Was there anything left over from those experiences? Yeah.
That's right. So no, they seem to resolve completely and spontaneously after the 15-minute period. In fact, his visual acuity had been checked during the Santa Barbara admission, and each time it was 20/20, both eyes as well. And he did not describe a persistent scotoma either to them or in my questioning when I got to know him more in the past few months.
Excellent. Thank you.
And excuse me, Dr. Shabib wants to know if there's a physical exam on him.
Yeah, so I didn't put it because of the time constraint, but the Santa Barbara admission basically was notable only for the encephalopathy and confusion. The medical records from that hospital, unfortunately, don't detail the mental status portion of the exam, but everything else on the neuro exam was intact and non-focal.
And what about features of the general medical exam? Anything of any conspicuity, something you want to bring up, or not really?
No, not really. The physical exam and the neurological exam were actually both intact, with the exception of the mental status, in which he was still having quite a bit of the confusion, lack of orientation, that sort of thing.
Okay,
And
fabulous.
we have another question from Kumar Green. He wants to know if the visual aura was only present in one hemifield.
Yeah, so that was very difficult to elicit from both the medical record and from what the patient recalled, because he basically described it as throughout or diffusely throughout. So that was very difficult to pin down. And so unfortunately we don't have a specific hemifield description.
But you did mention that he covered one and then the other, and recognized that what he was experiencing was in both. It was in both eyes, so
Correct.
Not a single eye field, and it didn't appear to be localized to a particular part of the field from each eye. So he did do the little trick. He did cover and said, yeah, it's in both eyes.
Right, yeah, but not limited to a hemifield. It was diffusely throughout from his description.
Okay.
Right, and so just to go on, basically I wanted to give you a snapshot of the DWI ADC from Santa Barbara. So this is what prompted the entire stroke workup, and you'll see the labs coming up on the next slide. Basically, they're very tiny punctate diffusion restriction lesions. Some of them do have a clear correlate on ADC, others, however, do not. And they appear to be throughout. It's not on these slides, this slide, because I ran out of room. There was a very tiny punctate one in the left brachium pontis, basically, but the cerebellum did not seem to have any. But this is what prompted the stroke workup. The lab work, the workup that was...
I just asked a quick question, sorry.
Yeah.
Do you have the sagittal flare?
I do.
Because it looks like there's a corpus callosum lesion.
I do, but I wanted to save it for, I wanted to save it for the following one when we got the imaging at USC. It's coming right up in the next few slides. And the reason why I saved it for the next slides is because it's practically identical to the one that we saw from Santa Barbara. But I'll be showing it to you very soon. But I just wanted to give you an idea of the workup that had been done before he came to us at USC. At Santa Barbara, what you'll see on this slide is basically they did quite a comprehensive workup. They covered all of the infectious possibilities. They were concerned about vasculitis and stroke, so they did the stroke in the young type workup as well. They did autoimmune. They sent the paraneoplastic and autoimmune panel from the serum to Mayo. That was negative. And then they also sent the serum NMO to Mayo. That was negative. The MOG was not included on that workup. And the CSF labs from the Santa Barbara portion, what you'll see most notably, the protein elevated at 145. Part of that is the infectious workup, which was negative. The encephalitis panel was negative, and West Nile, that sort of thing. Oligoclonal bands were 0 from the CSF. So just wanted to give you an idea of the workup that had been initiated. The only abnormality up here that you'll see is the von Willebrand factor, which was slightly high. Yeah. That's it.
Fabulous.
Yeah, and so basically the differential at Santa Barbara, for them, it was quite broad, understandably. And I know I've only given you a glimpse of the imaging, but I'll be giving you more. Highest on their differential at first was stroke, vasculitis, but of course, you know, they wanted to explore the idea of more demyelinating etiologies, MS, ADEM, NMO. But basically, in a case like this, many possibilities are there, so I wanted to give you a quick bird's eye view of the differential. What they did for him was that they gave him steroids, 5 days of Solumedrol. There was improvement in the encephalopathy and also the migraines, responded very well to that, and then he was discharged home on a taper of prednisone 60 daily. No official diagnosis was given at the Santa Barbara admission. And then the new year turns around, and then we see him for the very first time. He presented to our neuroimmunology clinic, and due to the severe encephalopathy, he was directly admitted to our hospital at USC. at Keck Hospital. The workup again was, why was he having such severe encephalopathy? We reviewed all of the Santa Barbara labs. The mental status then, to give you an idea, was a bit off. He's a very smart guy, very sharp. He's a prolific writer. He was disoriented to place. He still thought that he was at the Cottage Hospital in Santa Barbara. He wasn't oriented to the date, wasn't aware that it was a new year. When given to spell world backwards, he spelled rural, and he actually did very slowly. And then when given world again as a prompt and said, no, actually, could you spell world backwards? He started to spell backwards.
By the way, Horatio, how did he do at that, by the way? That's a surprise.
He was very, very slow, and basically he didn't make it all the way through spelling backwards, all the way through, like midway, like after the W he stopped and became a little bit confused after that.
Yeah. I don't know any neurologists who can spell backwards either. So okay, keep going.
That's right.
Except for Lissac. Lissac knows all these words, but okay, keep going. That's great.
Sorry. So I wanted to just put on this slide, just because of the constraint on time today, the very quick synopsis of the essential workup that he had at Keck, which was significant. So that's when we had ophthalmology involved. And he was noted to have bilateral BRAO, more severe on the right. He also was described as having optic nerve disease.
I got to stop you. I love you. You're wonderful. You're really moving. I think you talk faster than Frohman, but that's according to me, and I'm one of the Frohman. So, but can you just describe for those on, because we've had some peppering now with some students and residents. So for those who are not imminently familiar with the ophthalmologic lingo, could you sort of?
Of course.
Oh yeah, you're on a roll. I want to make sure we don't leave anybody to the dust.
Absolutely, absolutely. So basically, branch retinal artery occlusion, and I have some pictures coming up on the next slide. But basically, it was noted that he had that. The major vessels were fine; they were intact, no obscuration there. And because by the end of the Santa Barbara admission, he had already been complaining of tinnitus. By the time he came to us, it was tinnitus and hearing loss. And that was a new part of the history that had not been fully elucidated. And he complained of it more on the left ear than the right, but it was bilateral. We did manage to get an audiogram while inpatient, and he was noted to have a loss of hearing, sensorineural hearing loss on the left ear. A little bit less on the right. Just to give you an idea of the treatment.
Could I stop you for just 1 second? This is beautiful, but let me just ask you one question. We hear about BRAOs, and many neurology, particularly in training, oftentimes don't see this, and for reasons you probably know, direct ophthalmoscopy. Generally, you can get the guys to get a good look at the disc if they're working at it and they have it in their pocket. Isn't that right, Galetta? But many of these tend to be a bit further out, a little bit more peripheral. So with indirect and a lens, probably easy to see it before you start looking with photography. But what I wanted to ask about is the bilaterality of the hearing loss. And we have this great faculty and great folks on and fellows. I wanted to ask Roberto Alejandro Cruz, who's our current fellow here at Dell Medical School at UT Austin, and just see if this jives. I mean, Alex, do you want to make a comment about the simultaneous evolution of hearing changes? There can be asymmetry, but when it's truly bilateral simultaneously, what are we thinking about in terms of localization if you put that with one lesion?
I will think that if we're talking about the CNS with only one lesion, will be in the trapezoid body. That's where I will think of looking.
Yeah. So the entry and the movement, the trajectory of the acoustic stria, that's exactly right. So in the tegmentum and the most ventral aspect, I mean, clearly you could have two lesions, simultaneously inner ear, but Horatio, you may get to this, but do we know in Sussex that, it is a highly conspicuous observation about this bilaterality of hearing loss? Do we think that they're in sequence peripherally, so there are two, or do we think this really may fall into line with the lesion in the entry of the acoustic stria? You know, there's so much redundancy in the auditory channels that it's pretty unusual to have features like this. That's why I'm asking.
Right, no, absolutely, and I'll be getting to this first. So yes, absolutely, it's Susac. I don't think it's a surprise to anybody at this point.
No,
But
it
yeah,
might be, but I'm not saying that's what it is. I'm saying a classic feature of bilaterality in terms of,
right.
you know, localization. And we do go back to our roots as neurologists in terms of the history exam. You're doing a beautiful job with that. I just didn't want to run over anybody junior who, if I asked, think about, is there a place where you could do this bilateral simultaneously with a single lesion? That's not easy to do with auditory channels.
Right, absolutely, and I agree with Alejandro's response, his explanation as well. On the imaging, we did not find any lesion in the area where we could localize it to bilateral hearing loss. And then in the literature that I have read, there isn't anything specific saying that unilateral or bilateral is more common than the other. It just, any one of those options can happen, either unilateral or bilateral hearing
and
loss.
For Alex's credit, with the patient we saw this last year who presented like this and was holding up the audiograms, and Alex very astutely was seeing them at the same time, neurosensory. I won't name names, but a world-class neuroradiologist said there was no lesion to explain this. And Alex went back and went through the sequences and correctly on the axial, sagittal, could not see it. But on the coronal T1 with gadolinium, you went through very carefully. And Alex was able to pluck out this sort of incomplete ring enhancing lesion that was exactly in the most ventral portion of the tegmentum at the pontine level, a little bit lower pons. And she did get better with anti-inflammatory therapy and with plasma exchange. But sad thing was, because the absence of a lesion doesn't mean there's not a lesion, but she was told this was all in her head. And that was very unfortunate. But of course it's correct, it's in her head, the brain's in the head, the lesion's in the brain, but that's not what they meant when they told you that. And I just want to call out this fabulous fellow, as you are, for really taking the time and being very, very astute.
And Horatio, I apologize for the interruption, but we do have a couple of questions in the chat box.
Yeah.
Another question from Dr. Shabib, who wants to know how the course of his disease after being discharged was in the first place, and when did he develop encephalopathy? And then
That's
the second
right.
question is from Kumar Green about any vestibular evaluation, VHIT, calorics, or VEMPs.
Right. To the second question, no, there was not vestibular evaluation formally per se. And to the first question, that's actually what has made this case extremely difficult and challenging, is the persistent encephalopathy, and I'll get to it on another slide, but basically status migrainosus as well. And so that happened after this admission. If it's okay, I wanted to show you what we got during this admission. So the treatment, I put it there, basically the basic 5 days of Solu-Medrol followed by prednisone taper. And we also started him on IVIG at this point every 2 weeks as an outpatient, and then monitoring him carefully. This slide basically shows you a very brief bird's eye view of Susac. I don't have to belabor a lot of these, but basically the big triad that everybody considers with Susac is the encephalopathy, the sensorineural hearing loss, which we think of as bilateral, although, as I said, in the literature that I've read, there are instances of unilateral as well. And then the branch retinal artery.
And Horatio, remember the lore as well about Devix, which eventually became NMO and became NMO spectrum disorder. There used to be this lore about, well, it's bilateral visual loss and longitudinally extensive myelitis in synchrony. And you know, and I know, and everybody here listening, I hope, knows that's not true, because everything starts somewhere and it doesn't have to be simultaneous. In fact, in the majority of cases, they're not. So I really think that principle that you're underscoring is really, really important. So I'm glad you did that.
And can I just make a quick comment? You can have several years in between one symptom. Part of Susak's could have the branch retinal occlusion, the hearing loss, or the encephalopathy, which I think is very important and just highlights the need to follow up on patients over time, because eventually they may actually complete the triad.
It's a great point, and particularly if one is thinking about mechanism of disease and corresponding treatment, you may feel at the beginning, I think I know where this is going, and I think I know mechanistically what planet I'm on. Let's proceed with treatment as if that's the case. So I think you guys did a fabulous job, and I think Scott underscores a really important principle.
That's right, and that's exactly so. The big surprise, at least to me as a fellow, I had seen a couple of Susak cases as a resident, but they had the incomplete triad initially, and then eventually they completed it. This patient, it was very fast. Within about a month, we had evidence of the 3 of the triad. It's usually only in about 13% of the cases for the literature that I read. Basically, it's a microangiopathy. There's a lot involved in this, a lot of pathology, but I just wanted to give you an idea of what it is, so that you do see those microinfarcts. They can be located in many places, the cortex, the white matter, even in the deep gray areas as well. And you can see the leptomeningeal enhancement in about 30% of those cases. The epidemiology of it, it's heavily weighted towards a female predominance, at least 3 to 1 per a lot of the studies that have been written on this. And the onset can vary quite a lot, anywhere from 15 to 40 years of age onset, and then the range itself is also very vast, from very young, 7 to 72. There's a lot more that we haven't compiled, I'm sure. The symptoms associated with this is where it gets really challenging. So migraines are one, seizures can happen, tinnitus, obviously, the vestibular symptoms, and neuropsychiatric symptoms. There are actually quite a few studies that have been done specifically on this in people who had been misdiagnosed with bipolar disorder, but actually the underlying condition was Susak, because there can be instances of mania in psychosis, for example, paranoia, delusions, and then generally frontal cognitive dysfunction, which this patient definitely did have. And the big thing, someone asked about the sagittal, so I'll show you some of the MRI sagittal. The T1 hypointensities in the corpus callosum, I'll get to that very soon. This slide basically shows from our neuro-ophthalmology the fluorescence, the FA that we have for him. The right eye is more affected, so you do see more of the peripheral non-perfusion areas in the nasal and temporal areas. The left is a little bit less marked, but you do see also some inferotemporal area non-perfusion. They did note the typical gas plaques, which I don't clearly appreciate here, but that can happen as well. They usually happen past the bifurcation points of the vessels. And another thing that can be quite typical is the hyperfluorescence in the arterial walls, and that is due to leakage of the fluorescent in the vessel wall that is damaged. This is the T2 flare. I just wanted to give you some quick snapshots of some of the punctate areas affected. The genu, the splenium of the corpus callosum are definitely involved. And the T1 post with some of the leptomeningeal involvement and the enhancement as well, which affects about 30% of the cases. And this is the sagittal. So this is sagittal T1, and we can see the T1 hypointensities. Many times they're called holes or snowballs. I've also heard cannonballs. And then the linear defects as spokes. It's very typical for it to happen in the corpus callosum. And then eventually you can also see thinning, atrophy of that area as well.
By the way, Horatio,
not-
point out you go back. Can you see the hyperintensity at the level of the mid pons, which is in the front of the tegmentum on the right, the most right image on the sagittal? There's an area of high signal. I know this is a T1, but it'd be interesting to see if you have, I guess we didn't have a sagittal flare, right? Or any of these flare? I don't think so.
No, the sequencing unfortunately did not include it.
Can you maybe just comment on how this appearance maybe differ from MS?
Great question.
Absolutely. So again, it's very, in MS, we can see lesions that are perpendicularly oriented to the ventricle itself, and we see it more in the ventricular area. There can be some lesions in the corpus callosum in MS. The situation here is that these are almost punch holes. They're very well demarcated. They're punctate. They're specifically in the area in the corpus callosum itself on T1. I don't know if that answers it.
But,
yeah, and also just mentioning in the center of the corpus callosum, gives you sort of a high suspicion that this is non-MS corpus callosum involvement. And you had mentioned the leptomeningeal enhancement is also sort of a clue that maybe this is not your regular run-of-the-mill MS. I just mentioned that because a lot of these patients, and you may have mentioned this previously, get misdiagnosed as MS because they have white spots in their brain, regardless of the restricted diffusion, because we know that can happen with demyelinating diseases. But I think the clue, as you went over the BRAO, the hearing loss, you have these punched out lesions. I think they also are called moth-bitten appearance, Elliot, if I recall correctly.
Yes.
So, yep.
And the other thing that I think is very important, Horatio, which, this is really lovely presentation. If you look at how many of them there are, particularly to the right, there's not like one or two, there's a number of them. And yet, I think to Scott's point, almost all of them, maybe with the exception of the genu of the corpus callosum, I don't know if you can put your arrow on it, you'll see a linear area of T1 hypointensity that, yeah, in the genu toward the front, the other way, right there. So there you see the presence of a bit of a transcallosal band of T1 hypointensity. All the others are dots that are coming out toward us as if there was a cross section of a vessel cut off there. Whereas in the so-called Dawson's fingers, some of these lesions may extend from the ependema into the corpus or the corpus into the overlying white matter. But you're exactly right, they're coming out linear up. And if you look at these histopathologically, ultrastructurally, what are you doing? In the MS case, what you're seeing is, in a sense, the exocast or the endo-N-exocast of the postcapillary veins. And the reason why I underscore that is these are the vessels that are uniquely able to upregulate the adhesion molecules, which allow stabilization and then trafficking of mononuclear cells. So like VLA4 on circulating lymphocytes and VCAM on the postcapillary venular endothelium. When they bind and they come into the brain, they're coming up and down, almost like a spindle of that vessel, and coming out and circumferentially around, giving rise to that linear, that finger-like projection of the Dawson's finger. Very different histopathology compared to these, which you nicely analogize to what we see in the retina when we have these branch retinal artery occlusions. So it's a really great example of it. These are very small, but they also can be quite large, as Scott was pointing out, moth-eaten, but also the snowball configuration that you hear about. They can be quite large, and yet they can be wholly within the corpus callosum and not exit, and certainly not with a trajectory like they often do with demyelinating disease. Okay.
Yes.
And Horatio, we're just coming up over our time a little bit, so if you are able to kind of summarize the rest of your slides so we can.
Absolutely. Absolutely. I think that the rest of it, basically, this is the pattern that I've been with this patient. So we've had unsuccessful attempts to wean him off steroids. So we've discharged him on prednisone. So back in January, he was still on an IVIG every 2 weeks. We had planned Rituxan, which he did not get to start until March 6th for logistical reasons. So January and February were months in which he had continuation of the migraines with a lot of visual aura. It got to the point where he went into status migrainosis with multiple local ED visits where he lives. In addition to that comes the encephalopathy portion of it, which consisted of many things: insomnia, anxiety, agitation, a lot of mood issues, irritability, some of that aggression, which was always very verbal, it was never physical, and worsening confusion. Very labile mood, and then it culminated in a seizure event that was witnessed. It was described as a general tonic-clonic type seizure by his parents who witnessed it. There was a postictal period that they also mentioned he had, but he didn't have any of the other typical seizure characteristics that sometimes we see, like tongue biting, urinary incontinence, etc. Nevertheless, this prompted a quick admission to Keck for a second time. There was very high concern that he was infected, so all of that workup was done and was negative. The CSF was repeated. Again, protein consisted of being still quite high, over 100, 110, and then all the infectious workup for that was negative. The opening pressure,
Horatio, I'm sorry to interrupt, but given the dependency upon steroids, maybe Andrew Goodman, I know, is on, and of course Bob Lissack is on. Any comments about the place for thinking about a steroid-sparing agent, notwithstanding where you may want to go, but with that very important conspicuous observation of tapering hitting a threshold, is there a place for some intervention that might facilitate your ability to wean those steroids? Andrew, any comment about that, or Bob?
Yeah, so we've tried Cytoxan in some of these people with some success.
Mm-hmm. And Bob, any other recommendations or considerations for a steroid-sparing strategy? I don't know if Bob left the building, but Horatio, I'm thinking about potentially azathioprine or perhaps mycophenolate.
That's right.
Perhaps the latter, given that it tends to have a bit more accelerated on time in terms of latency compared to azathioprine. But I've had patients with this as well as other conditions who appear to be stuck, and they've had a very nice response, but I can't get the steroids down below a particular threshold, and has an influence on where you go next and doing combo or not. That wasn't the intention, but sometimes I've been able to get out of trouble that way by the addition of a sparing strategy. In some cases, I leave them on it; they do quite well.
Yeah, somehow I got muted. Yeah, I agree with Andrew. I've had some success, anecdotal, of course, with cyclophosphamide on the basis of that's what I tend to use with CNS primary vasculitis stuff that Pat Moore and I published, and she did it published even earlier with a rather well-known immunologist who's seen on television daily.
Was that IV or is that oral cyclophosphamide?
I don't use oral anymore. I really don't. I prefer pulsing because I know how much I've given, and I know how well hydrated they are the day before, the day of, and the day after. And the dose you gave. Sometimes the oral will sneak up on you when you use it chronically, and all of a sudden you've gone past the magic number, and you're looking for even with protection, you're looking for bladder cancer or lymphomas. So I don't know about Andrew, but I tend to give it pulse and keep an eye on it that way. And the other thing is, just because we're running late, but rituximab has sort of become the use of everything, even when we don't know anything pathologically, at least I don't, in a lot of these diseases, that it's either B-cell or humoral mediated. I mean, rituximab would have minimal effect, and maybe Scott can talk about it, on a subset of T cells that happen to bear CD20. but there are other anti-inflammatories that would, and again, the advantage of cyclophosphamide, some of the ones Elliot was talking about, is that they have effects maybe directly and indirectly, ultimately on all of the immune system. So this idea about rituximab for all, when you don't have heavy evidence for B cell or antibody mediation of a disease, we've seen, in fact, Dr. Sheb has had a patient who insisted on rituximab for a disease where the pathology said he needed anti-IL-6 and or anti-TNF. So, this rituximab, I like it, but it's being used almost like we used to use steroids when we didn't know what else to do.
For this disease in particular, I know we have Steve Galetta and Laura Balser on. I can't resist asking them, two world-class neuro-ophthalmologists and terrific neurology people. So what would you guys say with respect to this diagnosis in particular and with Horatio's challenge with steroid-sparing issues? Steve or Laura?
Well, we've had success with gamma globulin actually in these patients. I would just point out the gas plaques are like cholesterol emboli, but they occur mid-arterial and not at the bifurcation with the classical cholesterol emboli occur. So we didn't really see them quite well, but they can be very diagnostic for this condition. So in terms of a steroid-sparing agent, I don't like to pull out the big guns, and we've had success with gamma globulin.
Well, this particular patient, Steve, apparently they've been using gamma globulin plus steroids, and they can't get the steroids down. So I guess you have to go to the next step.
Got to push you.
And cyclophosphamide.
We have a couple of people where we've done cyclophosphamide for 4 to 6 months just to cool things off, followed by Rituxan and or IVIG. The refractory cases often need a combination of CellCept, low dose, prednisone, IVIG. To Bob Lissak's point, there are anti-endothelial cell antibodies that have been found in Susak's disease. So I think that in part is the suggestion of a B-cell mediated disorder, but I don't know if that's true.
But the antibodies have been found, but the question I would have is if you look at the lesions, has anybody shown immunoglobulin deposits? I don't know. I'm asking out of ignorance. Or with, let's say, complement activation, which would then tell you not only is there an antibody, but there's some evidence that it's in the target and it's doing something. And the endothelial antibodies have been reported in other vasculitides where there's been no evidence that the complement or anything else has been involved, but they have antibodies, some of the autorogenesis. So, it's one thing to have the antibodies, another to show. I mean, I don't say it's anything not to use rituximab, but unless you know that antibody is pathogenic at the site of the lesion, then just having the antibody may not mean much.
So Horatio, Dr. Lissak is going back to the old principle.
So Scott, here, let me say something. It's Scott. I say something, and that is that rituximab, ocrelizumab work very well for cell-mediated diseases. And remember, in rheumatoid arthritis, that the benefit of rituximab preceded any drop on rheumatoid factor, and there's no clear association on a reduction of NMO IgG, meaning AQP4 specific antibodies, or anti-MOG antibodies when you get benefit with rituximab. So
there are
it
those
really is a cell effect.
Yep. And
yes, we all talk about CD20 positive T cells, but remember, B cells are APCs and half your lymphocytes are B cells. And it's been associated, Amit has shown very nicely in his work from 2010 that B cell depletion reduces Th1 and Th17 responses in MS patients.
So we need to move on to the second case. There's no question that we're running out of time. But to Scott's point as well, in MS, Rituxan can deplete circulating B cells by 99%, and yet IgG index, oligoclonal bands may not be changed at all. So I like that fact that
B cells, I agree with Scott on the antigen presenting and this CD20 T cells, but B cells can do other bad things, as we've shown, independent of immunoglobulin. So,
yes.
Anyway.
So I tend to think of that B cell, T cell, APC network is like it's kind of immunologic GPS. It's triangulation, and you may start by attacking a CD20 cell surface target, but there's a conversation going on between those B cells and T cells and other cells. So you can't really say it's a B cell therapy. And I don't think anybody's really saying that, but we want to be very careful that we know we're affecting coordinated or uncoordinated regulation of these immune networks. So Scott, I'm really grateful for you jumping in on that. Very, very important. So let's make this transition. Horatio, can I give you the floor with none of us interrupting for, let's say, 60 seconds to summate
Absolutely.
this case?
Yes.
Yeah, I think you could have the
Absolutely.
last word.
Well, thank you all. Actually, those are all great suggestions. So basically, he got, after the IVIG course every 2 weeks, he got Rituxan in March. So he's now status post Rituxan. The CD19 B cell counts are all depleted, but he continues to have encephalopathy, and the migraines are not completely resolved. Will depend on the steroids. So the next step that we were thinking about is actually the cyclophosphamide as an option coming up, and that's where we are with him.
Yes, and I want to put in one plug for the protocol. I'll send it to you through the email, and that's high-dose methotrexate with leucovorin and rescue. Not for everything, but it will shut things down. We've had treatment for calcitrant cases, lots of different etiologies, quite remarkable and fabulous, and this is from our paper in 2016 in the Journal of Neurological Sciences. I'll send you that, and Doris and other colleagues at the MS Society, I will send a picture that underscores Steve Galetta's point about the fact that these gas plaques occur along the longitudinal extent of the arterioles. We today had a case that was presented in our group by Ethan Meltzer, lovely presentation, turned out to be CADASIL, but there was a discussion about SUSAC, and I circulated a beautiful picture that had the branch retinal artery occlusions with an arteriole moving through, and you could actually see maybe 8 or 10 gas plaques that were like Indian file along the longitudinal extent, not at the branch point. So I will send both of those, the paper on the methotrexate and this figure, to everybody who's on. Will get that from the MS Society. So beautiful presentation, spurred a lot of discussion. Horatio, great job. And I think we'll go ahead and move to the next presentation that comes from the Wayne State team in Detroit. Bob Lissack is the mentor, and we have Mahmoud, who's the third-year resident but hospital manager in these times of COVID. And because of his interest, he took the initiative to offer to present to us a COVID-19 patient with neurologic manifestations, and we couldn't resist. So I want to thank him for taking the initiative and for Bob serving as his mentor and supervisor. And you know, Mahmoud, you couldn't be more fortunate because Bob is just incredible, as you know. So I'll let you take the floor.
Okay, thank you so much, Dr. Furman. Really thank you for the necessity for letting me speak. I think I have the case right here ready. Are you able, guys, to see the full screen?
Yes.
I see the margins are a little bit cut from the logo. Probably you need to change the dimension of the screen. Just let's see. Okay, if you guys couldn't see any of those, just let me know. So my name is Mahmoud. I'm a PGY3 neurology resident at Wayne State. I'm gonna present the case I saw a couple of weeks ago at the in the floor. My supervisor for this presentation is Dr. Lissack. He was not my mentor for the case, but I kind of like took his opinion throughout this process. Okay, so this is a 36-year-old African-American gentleman. History of ESRD and hypertension. He was brought by his sister secondary to mental status change. So according to his sister, the patient went to the hemodialysis as usual on Tuesday, March 24th. Usually he gets hemodialysis Tuesday, Thursday, and Saturday. And he had a full session. And then the patient disappeared after the hemodialysis, and then his family couldn't find him until he showed up next day on Wednesday around 10 p.m. So according to his sister, she described him as like being blunted, mute with lack of facial expression. His family investigated where he was, and they couldn't have an answer. So, but they knew that he drove himself back, and he was able to park his car in an appropriate way. They called the hemodialysis, which confirmed that he had a full session of hemodialysis, and he left the center without issues. The family observed that he was able, when he entered the home, he was able to perform simple tasks like taking few bites, ambulating without assistance, but he looked withdrawn, not interacting normally with his family. So they reported that this never happened before, no history of psychosis or depression. At baseline, he's very functional. He has 2 jobs. He's independent in all his ADLs. He doesn't have any history of substance abuse. They didn't witness any seizure-like activity. There was a report that he's having cough for 1 week. So in the ED, he was put under investigation for COVID. When I came to the room, I wasn't able to have an encounter with him. He was just, his eyes were open. He was not interacting. So he has a past his medical history is hypertension and ESRD. He had a renal transplant at young age because of renal failure, unknown cause, and he has right arm fistula. Medication-wise, he supposedly, based on the record, which were old, he's supposed to be on clonidine and minoxidil. The family couldn't get an access to his updated medication, so I'm not sure about the doses. The most current one. No family history of seizures. He doesn't drink. He does not smoke or does not use any recreational drugs. He has 2 jobs. One of them is a driver. The other one I forgot. But he is independent in all his ADLs. They didn't report that he had an exposure to chemical or toxic agent. His physical exam, his blood pressure when he presented was 138/98, heart rate of 95. He was febrile and sat in 93% of on-room air. General exam, the patient, when you enter a room, he knows he's awake, but not interactive. He was attentive to me when I entered the room. He looked directly toward me. The pulmonary exam was had crackles. Cardiovascular was unremarkable. He didn't have any sign of trauma. Looking for any meningismal sign, he didn't have any nuclear rigidity or kerning. His neurological exam, his GCS was E4V1M5, meaning the patient is awake. He opened his eyes. He is alert to verbal stimulation, but he was mute. When I mean mute, I couldn't find a clear aphasia versus it doesn't sound like a typical aphasia or language deficit. But he was not talking, not attempting to talk. When you walk around the room, he would track you, but he was not following command. When I gave him pain stimulation, he didn't even scream, or he didn't do any vocalization. When I give him pain stimulation, his shoulder, he just retracted and removed my hand. As far as the cranial nerve, I don't see any abnormality. He didn't have any facial asymmetry. He had blink to threat in the bitemporal visual field. He didn't have any restriction of the eye movement. He was moving all his extremities against gravity. When you hold his arm or legs, when you lift it up, he can maintain good posturing. I mentioned this, after 3 days of his admission, we started noticing rigidity as far as his motor exam, but otherwise nothing has changed. His sensory was limited, but he withdrew to pain, and his reflexes were 2+ in the upper and lower extremities with plantar reflexes downgoing. Even when he had rigidity, we examined his reflexes and were the same, 2+. So this is his initial CT scan of the head. It might lag at the beginning. So you can see there's some calcification hyperdensity in the CT scan in the cerebellum and the basal ganglia, a little bit right toward the frontal lobe. The report for the CAT scan was no acute intracranial process, and there was mineralization noted in the deep gray matter structure in the cerebellar white matter. So we did some of the basic lab and metabolic. It's a busy slide. I'll go through the most important one. His sodium was 134. His carbon, he had some metabolic acidosis. And again, this is kind of picture when he came on Thursday, like a couple of days after his hemodialysis. So he technically, he didn't miss hemodialysis. In fact, when he came in, it was like secondhand information. We were told that he missed dialysis, but after me calling the family and confirming that with hemodialysis, didn't seem the case. He has increased BUN. You can see slight increase in the CPK. He didn't have any white blood count. Lymphocyte, absolute lymphocyte was low. CRP was elevated. We checked his ammonia was 41. LDH and ferritin were elevated. I'll come to this later. And basic like TSH, B12, folic acid, and B1 were normal. So the toxicology, he doesn't make urine. We couldn't get a full screen. I asked multiple times and we can get it. But you can see, I don't see any abnormality in the main stuff. He tested positive for COVID, and syphilis and the blood culture didn't show any abnormality. So this is a chest X-ray. You can see bilateral pneumonia impression down here. Sorry, the font is white. It's a bilateral pneumonia. We did 20 minutes EEG. Again, when I saw him, I couldn't explain exactly the type.
Mahmoud, I'm sorry to interrupt. It's Elliot, but could you go back and could I have perhaps Alex? I'll pick on you again for fear that I don't want to upset anybody. But can you go through for me and underscore where you think the principal findings are here on the chest X-ray?
Yeah. So
not necessarily for COVID, but just in general. Can you just point out for us what are the most conspicuous findings here, both either for the lung fields, but also for the heart itself, its size and shape?
Yeah. The size of the heart reported to be normal. You can see the loss of the cardiac margin, which can be high because of the increased infiltration. You have a patchy infiltration all over. This is what, and you can also did not really appreciate the right the diaphragm. I don't see any major central in the trachea abnormality. They can report some. I'm not sure if they reported it, but like you can see some of the bronchogram right here. It's not very typical, but those are the findings. I'm not the chest X-ray expert. I realize
is it me, or does the heart look a bit big and the shape looks a little boot-like? But maybe I'm overcalling it. But at least you know, if you look in the left silhouette, it looks certainly the right side looks very good, but it looks a bit big and boot-like. But I may be overcalling that. Any other comments on just the chest X-ray? And I bring it up because everybody's talking about testing. Let's remember that PCR, I've heard nobody talking about type 1 or type 2 errors, but the type 2 error, the false negative on PCR may be as high as 30%. Whereas if you look at chest CT for characteristic ground glass, peripheral, silver dollar shaped kind of lesions, we're talking about a sensitivity of 98%, at least in the studies that have been reported so far, just in terms of observational ascertainment. But this doesn't look terribly abnormal to me. I see the fine points, but it didn't.
No, I agree with you.
Okay, let's keep going from there. And
Okay.
there are
Yeah,
no
so we
other
did 20 minutes EEG. Good to go?
Yeah.
Okay. So the 20 minutes EEG, we can see it's generalized slowing, giant high amplitude delta activity, intermittent with a little bit faster rhythm. The patient here was awake. And then it was reported as a GERDA, and it was seen in 30% of the recording. They report as a moderate degree of encephalopathy. We didn't see any epileptiform discharges. He didn't have any seizure or something to point toward post-ictal state.
Mahmoud, would you just, for the young folks on, would you just give us a definition for FERDA, for the acronym you're using, just to make sure that it's not flying over anybody?
Yeah, I said GERDA.
GERDA. I thought you said
GERDA.
FERDA.
Yeah, yeah.
Okay.
So, no, it's GERDA. Mm. So technically, I picked up. I think this is the most appropriate slide I found. You can see those big rhythmic delta activity, or I would say semi-rhythmic. A maximum in the frontal, but you can see it generalized. The left side is the blue, the right is the red, and you can see how it's kind of like rhythmic activity all over. So if you have a cut from the 4th second to probably around this second, you can imagine it's diffuse slowing, and then come back to be a little bit of faster activity. So yeah, this is what they call it GERDA, and it basically reflects encephalopathy pattern. Okay, all right. So we did LP in this gentleman. His LP pressure was 13. The LP came after on the 4th day. He already had like 2 sessions of hemodialysis. His basic metabolic has improved, but the patient didn't show any improvement clinically. So I'm going to pinpoint toward the the TAP was not impressive. His CSF glucose was 61. Unfortunately, I don't have the correlation with the serum one, but it didn't fall off like to be in a very low side or to be concerning. His protein was 40, not significantly. Luckily, I get the oligoclonal band yesterday, so they're both in the CSF and the serum. They're 0. His IgG index was normal. His nucleated cells were nothing seen. They commented about 67% of lymphocyte. I really couldn't understand, like they didn't see any cell. How did they come up with the predominance? But as far as the viruses like EBV, we tested CMV, VZV, and HSV 1 and 2. All of them were negative. We were not able to test for COVID. As of now, it's still not a valid test. I spoke to the head of the microbiology lab at our hospital. It seems none of the labs in the United States are now doing this. So, yeah.
Did you bank samples, Mahmoud? Did you bank samples of spinal fluid?
Yeah, that's a good point. Yeah. It's a good point. Dr. Lisak actually raised this up to freeze it. I was late. I don't think we didn't have any sample left. So unfortunately, I couldn't get it done this way. So during his hospital stay, summarize, he came with hyperkalemia, 8.4 potassium, and he underwent emergent hemodialysis. He had large anion gap metabolic acidosis. He had the 3 hemodialysis in the first 4 days. And then around the third day, he started developing muscle rigidity. We checked his ionized calcium, make sure there is no tetany or encephalopathy because of hypocalcemia. It was slightly low, 1.03, normal range 1.13 to 1.20. It's very narrow range. He got a bunch of calcium gluconate of 8 milligram. 8 grams during his day, which we were treating first of all to his hyperkalemia, but also we gave him additional. We didn't see any improvement. Hydroxychloroquine was started on the day of admission because of the high suspicion. He received 400 milligram, just one dose on the day of admission. We couldn't get him the what we recommended, the second dose of 400 and then 200 for 4 days. Because the patient was not able to swallow, and he had a whacking and weaning in his mentation. And then many of the doses skipped because of this. They couldn't get, I was a consultant in this case, they couldn't get the NG tube in place. They had to consult IR for NG tube insertion. He later, 10 days after his admission, we continued his hydroxychloroquine, and he get 3 more doses. He was started with the broad spectrum antibiotics for 7 days, including vancomycin and zosyn. Neurologically, even after 7 days, he didn't have any significant improvement. Metabolic profile was normalized. So we decided to do MRI of the brain. I pushed toward to get a contrast. Primary team was, concerned because of his ESRD, so we couldn't get it done. This is his in the left side, the DWI, on the right is ADC value. Also, again, here it's a little bit lag. So you can see that there is some hyperintensities with correlation with also hyperintensity on the ADC. So we were not thinking of stroke. Like you can see all of this. It has some correlation with it. So we didn't think it's a stroke. We thought it's an acute demanding process. I'll come to the next sequences in a little bit. So on the left side, the T2 sequence is not the best sequence. A lot of motion artifact, but I didn't add any more. I don't. You still see the cerebellar white lesions, white matter lesions.
Yes, cerebral. If you go back down, Mahmoud, to the cervical, yep, slowly, the cervical medullary junction, stop, and you can see.
Hold on. One second, sorry.
Oh, I'm sorry. Yeah, we just go to that low level as you pop through, even on that. So go back down one. Yeah, stop right there. You can see in the right dorsal medullary tegmentum at the back. Take your little finger and put to the little bit more right there, and a little bit brightness in the pyramid on the right. You can see that.
Oh yeah.
About this, yeah. So right. So we have a little bit of a. I'm bringing up the tegmentum because we talk about in this disease the respiratory embarrassment and more than enough damage and obliteration in the alveolar apparatus. But let's remember we also have lots of interaction from the carotid bodies, carotid sinus for partial pressures of CO2 and O2, and of course pressure back in the solitary tract in the respiratory tegmentum of the brainstem, principally medullary and some pontine as well. But go back. Exactly. Now let's go up a segment or two. This is so important because there are so few scans in the world that have actually captured any of this. So I hope you understand just how amazingly fortunate you are to get these. And you can see these snowballs in the cerebellar hemispheres right on the right and left, and both of these are the exit of the middle cerebellar peduncles, on both sides, and this very strange draping ventrally of the pons. If you go back down where you were to the right here.
Talk about this.
It's a very unusual signal, and it's very unusual in the sense that if you think about metabolic derangements, this is not our classic, for things like central pontine monolysis. We don't see crossing fibers, but I saw in one of these laboratory assessments you had demonstrated a slightly elevated brain natriuretic factor. I was wondering if you had serial assessments. In other words, if this patient had lung involvement, did they then have cardiac involvement? Was there any component of failure stretch might have increased brain natriuretic factor, low sodium? Was that looked at again? And I guess we'll see where we go with this. But can you run through now very slowly, going up and see what else we're seeing in the posterior fossa? And I can,
Elliot, what do you think about the theory that
And there is some cerebellar in the nodulus over here too. If you look, if you put your, I'm gonna be quiet and listen to what you just said. But there's a bright area on both sides actually. Yep. Come to the midline cerebellum.
Oh yeah, you're talking
There's
about
the
those,
bright
yeah.
fourth ventricle. But yeah, both those sides. I mean, you got enough in the hemispheres, but I don't want to overlook that the real midline stuff. But I'm sorry. Go ahead. Was that Steve?
Yeah, what do you think of the theory that the brainstem may be vulnerable in some patients because the virus is in the respiratory tree and then can climb up the vagus nerve and enter the medullary area as you showed? That is one of the main theories of why the brainstem may be vulnerable in this disorder.
Yeah, I've seen some theories about both vagal as well as the alpha adrenergic system maybe playing a role here. Maybe the encephalopathy, the fatigue, maybe it gets into the dorsal rostral pontine tegmentum at the locus coeruleus. But we are just at the tip of the iceberg. That's why I got to tell you, Mahmoud, this is such not only a privilege for you, it's a privilege for us, and of course, really all inspired and driven the initiative by Bob Lissack to make sure that this saw the light of day, because we have such a small experience based on things that have been published or people writing about this, but very little, because the poor guys in the ICU are just trying to keep these people alive. So many of them don't get a chance to go down to the scanner to get MR. Many of them are not being tapped. We're just trying to keep these people alive. So the key is we got to do something to left shift, keep people off the vent, and those who are on the vent, we want to get them off. But this is really the beginning of, I think, what's going to be the really, really important observations. You should not let this go. There are places where you could, either Cold Spring Harbor, my virology colleague, Matt Parsons, taught us about that. But the major journals are really being very liberal in terms of your ability to submit and have these see the light of day, because we're all desperate to see what the semiology is, not just neurologically, but across the spectrum, but also in terms of, as Steve is bringing up, what's the neuroanatomic correlation for the problems we're seeing. There's more than enough damage in the alveolar tree. There's some people who they're doing well, they're satting, and then boom, in minutes they're gone.
Exactly.
They're gone. And like, oh my God, this is, and they're ventilating, they're on, assist control. It's early, they may not have suffered the sort of catastrophic obliteration of the tree, and yet they turn off. And the question is the recipient in the tegmentum, the reticular formation that, we all learn about, is it not responding? Has there been, we know that the distribution of the ACE2 receptor, it's not only, it can be in the brain, it's in the hypothalamus, it's olfactory. I guess you may get to that in terms of this issue of the incidence of anosmia and dysgeusia for smell and taste. But I think Steve is exactly right. One of the things I'm really, really worried about, if you think about left shifting the hysteria and the panic button, is what is the disposition of the virus, and not just ACE2 receptor distribution, but there's some evidence that that distribution can be induced. There can be induction of the ACE2 receptor, which means if there's virus around, it has a place to attach and exert its tropism centrally, particularly in these very delicate areas. So I'm not trying to be, focusing on minutia, but this is where the game ultimately can be lost very quickly in these patients. Is this, the tegmentum of this brainstem is at risk. And what you're showing with this case is you can see it all around it. It's cerebellar, it's peduncle.
Exactly.
But if you look at the fine points here, I'm really, really worried about those areas. Exactly what Galetta is going after here.
Yeah, no, I completely, that's, your point was definitely, I'll come to this in a little bit in the slides.
Okay.
This observation was very important, and then especially now in the JAMA now, that Dr. Lissack has probably circulated. Yeah, those even like what you're talking about, it was confirmed on a few cases in the pathology. So I've observed a lot of patients, they're doing fine, and again, boom, they're like coded. So
Exactly right.
I believe there's something.
I'm with you.
And the flare, yeah, I'll pinpoint so you can see all of this lesion very nicely in the cerebellum.
And it may be harder in the tegmentum on flare. let me just point
Yeah.
this out, is that, for the big areas, flare will, well, hold on a second, go back one there where you were. So right dorsal lateral, the other way.
Okay.
1, 2, 2 cuts, one, next one.
Let me try to do it carefully. One more.
Yeah,
Okay.
right, go back down one. Right, if you look really carefully with your arrow, follow the tag. That's right, follow the tag right there. Boom, where you were. If you look very carefully, go to your left.
I see what you're saying. The
You'll
whole.
see that little subependymal area of brightness coming from the fourth into the tegmentum on the right dorsal lateral pontine tegmentum. And Teresa, my wife, the Better 7/8 Frohman, did a beautiful study on 58 consecutive patients with MS and INO, all 58 of which had lesions within the MLF on proton density, 88% on T2 and 67% on flare. And when you see it on flare, it's pretty, but it can miss, particularly these small pontine tegmentum, midbrain tegmentum. So you sometimes you got to have different sequences in order to capture it. So my go-to sequence is to make sure you get at least 3 millimeter cuts on those axials and have at least a T2 or a proton density to accompany your axial flare. Anyway, so I'll stop and let you keep going. This is very, very important. Are you already writing
so much.
and getting ready to submit this?
Yeah, we started writing this up. So this kind of lecture kind of like made me go and do some of the literature review. Yeah, so I completely your point was exactly right. As far as we also, Dr. Lisak, we're thinking the same. Coming also up a little bit, you can see a few lesions. I'm sorry, this is a little bit lagging. You can see some lesion around the thalamus, and we can see they're more of and again I'll come to this in a little bit. You can see it's a more of possible demyelinating, which we're anticipating. So this is again
you're able to get good cuts through the third ventricle and the hypothalamus and the I don't know as you came up, but the other question is, are your slice thicknesses for some of the fine structures, are they thin enough? Because a lot of times I have to, really beg to get the 3 millimeter axials through the brainstem, but then you come up and you're looking now, want to look very carefully at third ventricle hypothalamus, kind of like that AQP4 distribution, nicely published in the archives years and years ago by Sean Pittock about NMO and lesions and corresponding distribution of the AQP4 epitope. But it would be very nice to see a similar kind of, for example, the ACE2 receptor distribution, and to get those cuts through the third. I see a little bit of it here now in the third ventricle and up toward the anterior commissure, to make sure that you're also getting 3 millimeter cuts axially through the supratentorial compartment. For this case, for patients with COVID, to really see that distribution. The 5s just don't make it, 5 millimeter cuts. So
yeah, that's again, it's unfortunately, like when we're dealing with the COVID patient, it's been really difficult to even get him to scanner. I have just the basics sequences, T1, T2, and the flare. Like I wish I was able to do some coronal cuts, some more T1 cuts. They kind of like just want to make that it's a quick MRI.
Any cuts through the olfactory? Through the olfactory system?
Okay, so yeah, we can. I see it. There we go.
Mm-hmm.
Yeah, probably one cut. Yeah, this is what I have.
So you have a hyperintensity there coming out at the interpeduncular fossa, which normally you'd have the mammillary body, and of course the mammillothalamic tract that part of the PAPE circuit where it's on its way to the anterior thalamus, but not on this cut, but the one above it. But
Yeah.
so yeah, there it is. So Steve, any other comments on or anybody else? Happy to have the help.
Yeah,
Bob,
so
what are you thinking?
yeah, so last week we saw a very similar case in a young man, COVID positive, but he also had very similar lesions, but he had hemorrhages, tiny punctate hemorrhages inside of these white matter lesions, which were deep, concentrated around the thalamus. You know, the differential was whether or not this was some sort of reversible posterior leukoencephalopathy, but in the end,
Like crest. Yeah.
acute hemorrhagic leukoencephalitis, you know, the most severe form of ADEM, was what we found. And so, you know, we're seeing these very severe demyelinating cases that, you know, you may have seen once or twice in your life, and all of a sudden you're seeing two.
Yeah. And the one published was that severe bithalamic hemorrhagic necrotizing encephalitis. Exactly so. It's one of the scariest things I've ever seen. And
Look, almost identical to that case that was just reported.
Yeah.
I'll just make a comment. This is not a post-infectious demyelinating disorder like we'll commonly see cause lesions like this, or even sort of a parainfectious that's not directly related to microbial destruction of cells. So that Elliot had mentioned neurotrophic, that this particular virus is neurotrophic. And so we're going to see some really nasty CNS lesions that are going to be really tough for our patients to recover from. And I just make another plug for the COVI-MS registry for the patients that we're seeing and the importance of this, because we may find that there is a differential treatment effect with our patients, whether it's those that are on certain drugs that, you know, are cell traffickers versus immunosuppressing drugs, or even protective effects, like I've heard Bob Lisek say, of interferon having antiviral properties, which could in the future lead to treatments against some of these viruses. So really great job on presenting this, and definitely worth putting out there for publication.
And Scott and Bob and Mahmoud, the other thing is, you know, the kind of activity we're seeing in the lung, and we've had the privilege of working with Matt Parsons, who's a virologist at Emory, whose former life, meaning a few months ago, was primarily telescoped on HIV, and we're now collaborating on some works looking at COVID. But the point being made that when you look at the alveolar apparatus, it couldn't have been a worse, more vulnerable target, because not only is it a target, you're having the activation of different limbs of the immune network that in 80%, they seem to go labeled line, develop an antibody or other plasma factors, they get over it. The 20%, and particularly the proportion of those who really go south quickly, part of this is this irrationally exuberant coactivation of innate and adaptive and becomes maladaptive limbs of the immune response. If this is similar to what's going on in the brain in some of these cases, like Steve, Galetta mentions this, you know, bithalamic, hemorrhagic, necrotizing encephalitis. This is really devastating. And again, it brings me back to thinking about not the surgical strike IL-6, IL-1. We need something broader spectrum, which is why we're focused on this hypothesis paper. And I'll just give you the punchline anyway, which is looking at this high dose methotrexate with rescue. And I would encourage you guys, I'm going to ask Doris at the Society and colleagues to circulate this paper again, because this original paper we published in 2016 was really about so-called treatment recalcitrant fulminant inflammatory syndromes of the brain and spinal cord. And we rescued every single one of those patients. We have since given it to a number of patients and colleagues as well who have had fulminant post-viral syndromes. And I would agree with what Scott said. I'm not talking about a post-infectious set of mechanisms. It's the infection that ignites or pushes the panic button. And then the subsequent problem is the uncoordinated, poorly regulated activation, complement, other innate limbs, adaptive responses. This is a panic button. And in fact, our acronym for that is pleiotropic amplification of neo/native inflammatory crisis. And Scott, you're exactly right on that. I think this is not our typical post-infectious. This is a infectious trigger of these uncoordinated inflammatory limbs. And it couldn't be worse to be hitting the thalamic switchboard and also to be hitting, of course, the alveolar apparatus for gas exchange. So we may be seeing a new set of mechanisms we need to recognize, because who knows what's coming out of, whether it's the Chinese market next year or where else. But these zoonotic agents that are jumping from other animals to humans looks like worst thing I've ever seen.
And that's what our pulmonary critical care folks have said. We have a few of these people in the ICU, and the ARDS and the multi-organ failure that they're seeing is just above and beyond what they've ever experienced.
And so I'm not about 10 minutes over time now. So if we can just let Dr. Shabib wrap up really quickly, that would be great.
Okay. Because I know there are a lot of people on the line who are waiting to go out dancing. No, they're not. But go ahead, Mahmoud. Okay. We're very grateful to you. But yeah, we're going to give you the stage, and my wife is going to come over and choke me so I don't say anything. Keep going.
Okay, so just a quick about the other sequences. And in the left, we have the echo gradient flare again in the middle, and the T1. You can see those hyperintensity in T1 in the same distribution we saw. Okay, very fascinating MRIs actually. Okay, so the MRI report came as the bilateral symmetric diffusion restriction and the deep cerebral white matter and bilateral middle cerebellar peduncle is consistent with acute demyelination process. Their differential was hypertensive encephalopathy, hypoglycemia, PRESS, and osmotic myelinolysis. So I'll just drive quickly about the discussion about this case. So the patient has mental status change, didn't improve after repairing his electrolyte. MRI could be possibly demyelination in the deep brain structure and cerebellum. When he presented, his blood pressure was normal. So we were not thinking of PRESS to be really on our differential. And especially with the MRI, we usually see more vasogenic edema and more like posterior lesions. So we couldn't give him gadolinium because of his ESRD. So on the second hand, the osmotic demyelination syndrome, it can happen after hyponatremia or like BUN, any other electrolyte shift like BUN shift. And then we can see extrapontine myelinolysis. But this is more characterized by edema and demyelination, more edema and demyelination. So in the case series, so those people who develop osmotic demyelination syndrome after hemodialysis were followed with another MRI. So most of the lesions were either completely improved or rapidly resolved or rapidly improved. So the article was favoring transient edema rather than just acute demyelination. So I attached a couple of images about the how we usually see the extrapontine osmotic demyelination. Again, I think it's more of edema around that we really didn't appreciate in our MRI. So usually this is clinical manifestation also could be loss of consciousness from obtundation to coma, or also GTCs. So our patient, his sodium was 134, and having been corrected somewhere before he come in, it's unlikely.
Do we have information on how, if we had serial measurements, was there ever significant hyponatremia? I saw that one brain natriuretic factor. I appreciate that, but did we have serial? I'm sure we did, but can you tell us what the nadir was in terms of the sodium? Was it ever significantly low? And if so, how was it corrected over what period of time and with what, or without?
Yeah, so he came with sodium 134. This is the lowest value I was able to see. His whole sodium was ranging between 134, 136, but he's never been really hyponatremic. It's
So that's
very,
going
yeah,
to be a hard sell because that's normal. And the natriuretic factor, I don't know how many assessments there were, but if we really didn't see that, I'd be much less concerned.
right.
That was it was slightly elevated. I think you said it was like 119, but
Exactly. It will be, in those
I had a
cases, it'll
patient
be
last
maybe,
month where it was over 1,000. Now we're in play, but the 119 doesn't excite me, and we don't really see anything that looks like a significant sodium problem or a correction issue. So, you know.
Yeah, and then his B1, B12 were normal, so this also can have different manifestation. So we have presumably a demyelination lesion close to the thalamus, which I think this is the major hit as far as if I put it along with the EEG with encephalopathy picture, with his being, I think those lesions are getting him hit with being encephalopathic. So the only evidence we have available is his COVID positivity. So it was reported and then recently published in JAMA that this is the same series that was taken from Wuhan about the manifestation of the central nervous system. So we all know dizziness, headache, impaired consciousness. I'll stop here a little bit about the necrotizing encephalopathy, which was also reported. Now the brainstem, I don't know if you guys are, the brainstem infiltration is another thing can change the game, as Dr. Furman said. Very important to follow those cases, and seizure as well. I found more articles about the PNS manifestation. Like you can see cranial impairment, taste, smell, vision, and majority of cases that I had, they had elevated CPK involved in the muscles. I don't see
There's a lot of myalgias as well, and I think there was, in fact, a very, very severe case of rhabdomyolysis. So you can go and keep going. In some of these cases, there are one here, one there, but it's demonstrating the possibility of this broad distribution of problems. So that's exactly right.
Yeah.
And
so I can find, I'm sorry, Dr. Furman?
There was a case of Guillain-Barré as well. There may be more than that now.
Yes, yeah. Right.
Yeah, we have seen Guillain-Barré and oculomotor palsies as a manifestation of this disorder, thirds and sixth nerve palsies.
There's been some suggestion of Miller-Fisher-like syndrome or Bickerstaff's-like syndrome, or just, it may be viruses in there in some cases with a basilar meningitis. So pick the cranial nerves you want. You can pick them off.
Yeah, that's exactly right. Yeah, I saw many articles speaking about this, and in fact, also, and since we don't have, I can find a report of central nervous system demyelination per se that is reported from COVID-19. But ultimately, a lot of encephalopathies has been reported, like whether this is from the hypoxia or even people were not hypoxic, they're still encephalopathic. So again, we have a direct central nervous system involvement of the virus. Some of these clearly metabolic, the encephalopathies, but also not certain. So we also established that hypercoagulable state was led by the COVID-19 causing strokes, vascular damage. So
very important point there on the microvascular, hematologic problems there, microangiopathy, which may have some interface also with irrational exuberant complement activation. So it's been raised the possibility that eculizumab, for example, the antibody against the C5 convertase may play some role there, as it has with hemolytic uremia syndrome and PNH, and of course in myasthenia and NMOSD. But I'm very concerned about this. And if you remember the Wuhan experience, there was elevation in CRP, so inflammatory markers. But this issue of hypoxia ischemia coupled with a hypercoagulable state is double trouble, and sets probably a lot of these patients up. And you may have triple trouble if they have an underlying comorbidity of cerebrovascular atherosclerosis, as well as, of course, coronary artery disease. Yeah.
Yeah, I just left the VA hospital yesterday with also a stroke for a patient. He was on Eliquis, and because of AFib, he ended up having a stroke. So, yeah, I think immunotherapy should be taking place in those patients when we have established
early.
Yeah,
Yes.
exactly. So, just similarly, we have established already the central demyelination and other viruses similar to COVID, like MERS, the Middle Eastern Respiratory Syndrome, and the SARS, which referred to COVID, SARS-CoV-1, that was spread in 2003. So probably COVID-19 is the same. So in summary, cytokine cascade is in response to COVID-19 could have caused the encephalopathy and this sequela, as Dr. Froman said. As of now, we are not able to test the COVID-19 in the CSF. Just a quick patient has been, I followed up on him yesterday, and there is no significant improvement, unfortunately. He's followed some intermittent commands to the nursing. He hasn't been back to baseline. He still requires NG tube. He didn't speak. So, which is another phenomenon I couldn't really, it's a fascinating, like how encephalopathy can varies in a degree, but the way the patient has alertness and at the same time his inability to speech, and I think it's not primary language, like hit from the brain language abnormality as far as region-wise, anatomy-wise. I think something more toward this cytokines and instead inflammatory response. I had another case I would put just in the side. I'm not sure about this. I had also a patient with COVID. She was mute for about 3 days. We thought it's because she related this to stress after she had COVID and then she didn't speak. Her MRI was not evident at that time. It was normal, but whether this is another symptoms like when you have loss of smell, or I don't know, could be another.
I'm glad you're thinking about that. And as my older daughter Ashley loves to remind her father when she puts her hands on her hips and says, "Daddy, aren't you the one who says the absence of evidence is not evidence of absence?" And you're exactly right. But I think a point that you're making, particularly with these bithalamic, lots of midline, that some of these patients may be transitioning in and out of, and some of them may not get out of, sort of an akinetic mutism. And you show me those midline structures, and we're seeing it again and again, whether it's cranial nerves or the olfactory system, or midline in the brainstem tegmentum, the reticular formation, the thalamic lesions, third ventricle and hypothalamic involvement. Just draw a line down that midline, and we know in the literature, irrespective of the pathobiological underpinning of those disorders, that neuroanatomic midline circuitry is classic for akinetic mutism and variants, nuances of it. So you're exactly right. Stress plays a role, but it's pretty unusual people stop moving and stop speaking. That's a tough one, and I think you've got your finger on that pulse. This is a midline CNS phenomenology, which you can get to different ways, and thank God this person came out of it. But
yeah, exactly. And when she improved, actually, she started when I first saw her, she was back to her baseline, and she was mad that we thought it's stress related, but she told my attending I was unable to speak. That is her theory. So thank you so much again. I think we ran out of time. I was very glad presenting this case. I was very glad to see this is my first time in this society. I'll try my best to do in the next future series, but really thank you, Dr. Froman, for
Mahmoud, I got to tell you something. Everybody's most people are at home. I know about time issues. Teresa and I have been co-chairing this since September of 2017, and I would say remarkably the vast majority of these have been on time. Everybody's happy, but people are so focused on time. We have time. This is very important for us to have had the opportunity to see this patient. So if my big crime or your crime is that we went over, it's a crime worth having. We need to learn about this now and in a hurry. And this was very instructive, and I'm really grateful to the folks on the faculty, Galetta, Scott knew some other folks that have written in some of their comments, Andrew Goodman, of course, Uncle Bob Lissack, you can't do better. In fact, I think he's the singular most important factor of this whole program for the almost 3 years we've been involved. So I want to thank the MS Society again for putting up with us and allowing us to go in these various directions and inserting you at the 11th hour. We thought we might have 3 patients presented, at which point my wife said she would be close to my ear with the cowbell, and just the threat of it works. But we ended up with 2, and you can see we used the entire time, but I think it was time very well spent. I know I've learned things. I learned things every one of these that I participate in. So thanks for doing that and taking the initiative. And Bob, thanks so much for getting him involved and clearing the way for us to do this. And I think we're on an earth vertical trajectory of learning here, and we'll keep it going and try to do our part. Let me just reiterate, don't forget Thursday, not Wednesday, as Bob pointed out correctly. It's going to be Thursday from 7 to 8 Eastern Standard Time. The MS Society has that teleconference with Avi Nath and others, and I think it would be very worthwhile tuning into that. And I want to thank again Kathy Costello for her confidence and trust in us. And and by the way, let me not forget to recognize the amazing comments made by Scott Zamdil, our co-editor-in-chief for the section in M2. So, Mahmoud, I can tell you we're going to be talking after it off about, this has been a fellow-run program. You're a third-year resident. You're the hospital director. We need that now in time of COVID. So we'll be talking about, is this one that should be translated from a webinar into a case? You have my vote, but I'll talk to Uncle Bob and talk to Scott and to Teresa, and hopefully we'll get back and talk more about that. This is very important, and you couldn't have done a better job. It was fabulous.
Yes.
Thank you so much. Yeah. And
Sarah,
thanks for
any
my
final
co-president. Yeah.
Any final comments?
No, thank
Sarah,
you so much for everybody. And Kathy did put the registration link in the chat box for the upcoming COVID MS discussion, so that's available in the chat box. Thank you so much for coming, everybody. Have a great night.
Yeah, I sent to Doris the picture, the retinal photograph of the branch retinal artery occlusion and the Indian file gas plaques. So you have that for distribution, and I'll also send around the high-dose methotrexate before and rescue, but especially to make sure Horatio gets that at USC as a potential treatment intervention for his patient with refractory Sussex who seems to be steroid dependent. So that's my last comment. And thanks, Sarah. You're one of the new additions, and you jumped right in there. You did a great job. Nobody scared you away.
No,
nope, she's fabulous. She's one of the team. Thank you, Kathy.
All right, see everybody. Thank you all.
Good night.
Bye.
Thank you.
Okay. Well, what happened?